going to be talking about patients with problems of the central nervous system, specifically the brain. Although there are many types of headaches, this chapter focuses on migraine and cluster headaches. Migraine headaches are recurrent attacks of head pain that are described as throbbing or unilateral, which is one-sided. Some of the symptoms that we might see are nausea, vomiting, light, sound sensitivity, or pain with head movement. The attacks for migraines can last as short as 4 hours or as long as 72 hours. Women are more affected than men, and these also tend to be hereditary. Women who have migraines are more likely to have major depression, and migraine sufferers in general are at increased risk for stroke and epilepsy because of all of the things that go on inside of the brain and the neurons. The cause is unknown, but a number of environmental, hormonal, and genetic factors can seem to play a part. Many people state that they have triggers such as caffeine, red wine, or MSG. You see MSG a lot in Oriental or Chinese food. Stress and weather changes can also trigger migraines. The main focus that we have for treatment of these patients is pain control and decreasing the attacks. There are 3 types of migraines. You can have a migraine with an aura, without an aura, and an atypical migraine. Most of your migraines will fall into the migraines without the aura. An aura is a visual change, such as floaters, that lets the patient or the person know that the migraine is fixing to happen. It's kind of where you see things in the air that really aren't there. If you look at the chart on page 85, it goes over auras a little bit in more detail. Stages of the migraine include the prodromal phase. In the prodromal phase, the patient has specific signs and symptoms such as food cravings or mood changes. The aura phase is present. Of course, they can have light and visual changes. They may have double vision. The headache phase, of course, is the actual, when the headache is coming on, can last a few hours to days. And then the termination phase, which is the intensity of the headache starts to decrease for the person. The postdromal phase, which is after everything is said and done, the headache is starting to decrease or may be totally gone. The patient may be fatigued, irritable. They may have muscle pain. The diagnosis made for migraine is based on history and physical, neurological, and psychological assessment. So how are we going to treat these migraines? Drug therapy, preventive therapy, abortive and alternative therapy. There's a list on page 855 that goes over a lot of the different medications that are used to treat migraines. Abortive therapy is used to help prevent the migraine in the aura phase or shortly after the headache has started, and this is done with a certain type of medications. Remember, several of these medications have severe side effects, such as rebound headaches, which is after the initial headache has subsided, another one will begin. A few of the more common medications are triptane, medications such as Imitrex, Zomig, and Maxalt. These meds are really useful in managing the nausea and vomiting and pain symptoms associated with the migraines. Topamax is also used, but is given in low dosages. Topamax can also be used as a seizure medication. Patients should always try to avoid those triggers such as the caffeine and wine and maybe just weather changes. There's also a list on page 857 that goes over additional triggers for the patients. A few things that may help decrease the headache are to lie down in a dark room, put a cool cloth on the forehead, sometimes yoga, meditation. B12 and magnesium have known to help as well because a lot of patients are B12 and magnesium deficient. So cluster headaches. Cluster headaches are just like they sound. They're an intense, but they're unilateral pain described as excruciating and non-throbbing, whereas the migraines are throbbing, the cluster headaches are non-throbbing, and they're really brief. They're usually 30 minutes to 2 hours. They are mostly associated with changes in the seasons and felt more around the eye sockets and cheek area. They occur at the same time of the day for about 4 to 12 weeks. They're most common short duration headache, and they're seen more in men. between 20 to 50 years of age. The cause is unknown, but some linkage to overactive and hyperactive or hypothalamus can be seen. So some signs and symptoms we see with the cluster headaches: tearing of the eyes, runny nose, ptosis, which is the eyelid drooping, edema of the eye, facial swelling, constriction of the pupils, and miosis. So an assessment of a patient with cluster headaches, they may have flushing, pallor of the face, bradycardia, and they can have some increased ocular pressure. Patients with cluster headaches need a constant and consistent sleep-wake cycle. The same meds that are used with migraines are also used with the cluster headaches. Some additions can be steroids and lithium. You want to teach patients to wear sunglasses during the attack. And another treatment that they are finding useful is high-flow oxygen therapy. At about 12 liters, the patient is in a sitting position, and this helps to reduce the vasoactivity of the cerebral blood vessels and helps to decrease their headache in general. Seizures versus epilepsy. There's a lot of continuity between these two. Seizures are abnormal, sudden, and uncontrolled electrical discharge of neurons within the brain. These neurons are just firing constantly. Things that we see with seizures are loss of consciousness changes, motor, sensory, and behavior changes. People can have one single seizure for no known reason. Epilepsy is 2 or more seizures experienced by a person. It's a chronic disorder in which the person has repeated, unprovoked seizure activity. So, talking about seizures, there are many different types. The generalized involves both cerebral hemispheres, your left and your right. There are 5 different types. Your tonic-clonic lasts 2 to 5 minutes. The tonic phase is stiffening or rigid muscles, especially the arms and legs. You have immediate loss of consciousness, and then the clonic phase is a rhythmic jerking of all extremities. The patient can bite their tongue, they may lose bowel or bladder function, and then this is followed by what they call a post-ictal phase, and this can last up to an hour. Patients may be fatigued, they may have a lot of confusion and lethargy, they may just sleep for that hour. And there are 2 other types of generalized that you can just please review on page 858, but these are the more common ones that you see. Partial seizures are also called focal seizures. They begin in only one hemisphere. It's most often seen in adults, and the partial seizures are less responsive to medical treatment. So the complex partial seizure, these patients may lose consciousness or kind of black out for about 1 to 3 minutes. They are unaware of their environment, and they may actually start wandering around at the beginning of their seizure. They may have amnesia after the seizure. The area that's most involved for complex partial seizures is the temporal lobe. So this may also be called a psychomodal or temporal lobe seizures. And it's really difficult to diagnose because the seizures are similar to a lot of the signs and symptoms of dementia and psychosis. A simple partial seizure, the patient remains conscious throughout the seizure. They may have just basically one-sided movement. That's why it's called a simple. Patients may often report an aura, and they may have a change in heart rate, skin flushing, and some epigastric discomfort. Unclassified account for all of seizure activity, and they really occur for no known reason. The secondary seizures come from an underlying brain lesion or tumor. They can happen from any type of a trauma. If you remove the underlying condition, either by surgery or chemotherapy or radiation, the seizures will stop. So when you're talking about epilepsy, primary epilepsy is not associated with any specific cause, but likely genetics plays a part, and primary is controlled most times through drug therapy. And primary and idiopathic are kind of interchanged terms. This chart is just a seizure classification that we just talked about, and it kind of shows you what areas of the brain that each of these seizures focus on, and some of the symptoms that we have just talked about. One thing I didn't talk about are absence seizures. It used to be called a petit mal. These patients are the patients that you would see just kind of staring into the atmosphere, and they're just kind of in a trance-like state. So seizure risk, they can occur from metabolic disorders, alcohol withdrawal, electrolyte disturbances, heart disease, very high fevers, like 102, 103, sometimes up to 105 or 6 will significantly increase the risk for seizures, stroke, and of course substance abuse. Seizures that result from these issues are not considered epilepsy. And realize that many different activities can trigger a seizure, things like stress, exercise, fatigue, caffeine, etc. And I put this little picture on here, or do's and don'ts when someone is having a fit. You know, things like you want to shout for help and never put anything inside the patient's mouth. Clear out their environment, make sure they don't have anything that could injure them. And then if the seizure continues for more than 5 minutes, the person should be taken to the hospital. So seizure precautions. Oxygen, you always want to get oxygen on the patient. Suction equipment at bedside in case they need to be suctioned. Make sure you have an airway in place, like a mechanical airway. IV access, because you can't give the patient IV medications if you don't have an IV. Padded side rails are kind of controversial, and in some facilities may be considered a restraint. Some reading other medications or methods can include laying a mattress on the floor in the case the patient fell off the bed. Management must be appropriate for the particular type of seizure. For simple seizures, sometimes all that's needed is documentation of the start and stop time, because most of these, stop pretty quickly. Seizure management, it depends on the type of seizure. Again, all you may need to do is document the start and stop and how the patient reacted. Observation and documentation. Patient safety, make sure that patient is laying on their side in case they aspirate or they vomit. No restraints of any type. And then, of course, like we just said, never force anything into the patient's mouth. So acute seizure management, the medication depends on the type of seizure. The tonic-clonic are what you see a lot of for seizure activity. The medications for tonic-clonic, of course, are Ativan, is what you see the most of, Valium. Diastat is used to help prevent cluster seizures, and it helps keep it from progressing to status epilepticus, which we will talk about shortly. And then patients are also given IV Dilantin. IV Dilantin helps to cut down on the risk of stroke. From the seizure management, they will get a loading dose and then generally be put on oral IV Dilantin, oral Dilantin. Status epilepticus is a prolonged seizure. It lasts more than 5 minutes or multiple repeated seizures over a course of 30 minutes. It is a medical emergency, and it is a potential complication of all seizures. Common causes can be infection, alcohol or drug withdrawal, withdrawal from their seizure medications, head trauma, metabolic disturbances. ABGs are drawn to identify the metabolic or toxic drugs in the body or any other causes from this seizure. Untreated status epilepticus can lead to renal failure and electrolyte imbalance. Things that we just talked about: establish the airway, draw your ABGs, hang normal saline. You want to be pushing IV push Ativan, diazepam. You can also give rectal diazepam if necessary. And then, of course, I just discussed the IV dilantin phenytoin, which helps to prevent cardiac arrest and further tonic-clonic seizures. For drug therapy, you want to evaluate the most current blood level of the medication if appropriate. A lot of times you're going to be checking these lab results every 6 to 12 hours. Be aware of drug-drug or food-drug interactions. Maintain therapeutic blood levels for maximal effectiveness. And dilantin is one of those drugs that you have to check pretty frequently to make sure they have a therapeutic level. Never administer Coumadin or warfarin with dilantin. And then, of course, document and report your side effects. So, patient and family education. Of course, compliance with their drug therapy is of most importance. People with epilepsy or seizures, they need a balanced diet, proper rest, and stress reduction techniques. Social services resources to assist with medication costs. These medications are very expensive and the patients may not be able to afford them. So some of these patients may need to be on drug programs. Evaluation of employment safety needed to decrease risk. Some things we don't always think about: construction workers, people who operate heavy machinery, pilots. If they have epilepsy or a seizure disorder, they may need to find other employment, as a seizure may injure themselves or others in their current vocation. And then vocational rehabilitation may be subsidized. A lot of states have vocational rehab specifically for patients like this, or for patients who have some mental disorders, to help regulate them back into society with a different career. So surgical management. Vagal nerve stimulation, or VNS, can be performed for simple or complex partial seizures, but not generalized. With generalized, it can result in severe neurological deficits. Basically, a stimulation device is placed on the left chest wall, just like a pacemaker, and it has an electrode attached to the vagus nerve. And all of this is connected to a little generator. The generator runs continuously, stimulating the vagus nerve. And this patient has a little handheld magnet. When the patient experiences their aura, they can push that handheld magnet, and that helps to abort the seizure. And then there are some other conventional surgical procedures that you don't really have to know a lot about. So at this time, if you want to take a little bit of a break, it'd be a good time to go ahead and take a break. I'm going to go ahead and try and get this particular video finished, but feel free to take a break. We're going to talk a little bit about meningitis. There are viral and bacterial. Viral is the most common. Meningitis is an inflammation of the meninges, especially the pia mater and arachnoid areas. Viral and bacterial are the main causes, although others do exist. The organisms enter the central nervous system through the bloodstream or directly introduced into the central nervous system from trauma, surgery, especially on the brain or spine. Patients who have an infection in the head or neck, things like otitis media, ear infections, sinusitis, or tooth abscences, are at increased risk for meningitis. Also, anyone with an immune-compromised system, cancer patients, anybody without a spleen. These agents can spread to the cranial and spinal nerves. Severe neurological damage can occur, along with intracranial pressure and, again, clot formation. Viral meningitis, like I said, is the most common organisms. The most common organisms causing viral are herpes simplex 2, the mumps virus, and HIV, also varicella, which is chickenpox. So you can see now why vaccinations are so important for children, teenagers, and teenagers going to college. The symptoms kind of vary by agent. Most of the time, the neurological symptoms are temporary and patients make a full recovery. So some of the signs and symptoms are Generally, you will see fever. They can have headache, photophobia, which is light sensitivity, indications of increased intracranial pressure, nuchal rigidity. Nuchal rigidity is neck stiffness. With anybody that's experiencing neck stiffness with fever, you need to think about meningitis. Positive Kernigs are Brudzinski's signs. Decreased mental status, and of course, focal neurological deficits, and then nausea and vomiting as well. Some of these patients also may see a red maculopapular rash, especially if the causing agent is an enterovirus. A petechial rash is seen with the virus in meningitis or meningococcal meningitis. And seizure activity can occur when the inflammation spreads to the cerebral cortex. So lab assessment of our meningitis, The most significant lab test for diagnosis is the cerebral spinal fluid analysis. So these patients will be having a lumbar puncture. Patients older than 60 or who immunocompromised or who have signs of increased intracranial pressure, you'll do a CAT scan first before the lumbar puncture. A broad-spectrum antibiotic should be started quickly, sometimes even before the lumbar puncture is done, to get the antibiotic into the patient's system. CAT scans can be performed, blood cultures, of course, to see if there are any other agents in the bloodstream, polymerase chain reaction, electrophoresis, CBC, usually the white blood cell count is elevated, and then of course x-rays to determine if there's presence of infection, like we talked about before, if there's a sinus infection or an ear infection or tooth abscess, things along those lines. So drug therapy for these particular patients, a broad spectrum antibiotic, they're going to need at least 2 weeks of IV antibiotics. Hyperosmolar agents, mannitol is used to help with the increased intracranial pressure these people may have. Anticonvulsants, because they're at increased risk for seizures. These patients will need a vascular assessment every 4 hours or more. You're going to be looking at their temperature, color, pulses, capillary refill. Steroids are controversial, but are given in some cases. And then you can use standard precautions with these people, unless the agent is a bacterial type, such as meningitis or H. influenza, which is the flu. Then you'll need droplet therapy. So, encephalitis is the last category we're going to be talking about. It's an inflammation of the brain tissue and surrounding meninges. Encephalitis is very severe. It affects the cerebrum, brainstem, and the cerebellum. It generally is viral, but can be bacterial, fungal, or parasitic. The virus travels to the central nervous system by the bloodstream or along the peripheral or cranial nerves or meninges. The virus invades the brain tissue and begins to reproduce, causing an inflammatory response. This causes your brain neurons to degenerate and they can't do their proper job. White matter in the brain is destroyed and it causes hemorrhage, edema, cell death, and then allows these hollow cavities to form in the brain. Death can occur from brain herniation and increased intracranial pressure. Herpes simplex 1 is the most common reason for encephalitis. Signs and symptoms include high fever, nausea, and vomiting. They can also have a stiff neck. There's a full list of signs and symptoms on page 866. You want to also assess their level of consciousness using the Glasgow Coma Scale. And remember, with the Glasgow Coma Scales, the higher the number, the better. Joint pain and fatigue are also common, as well as headaches and weakness. Lumbar puncture is done to diagnose the organism present, and then these patients are put on high-dose antibiotics as well. Another testing that can be done is an EEG to evaluate the brain waves for damage and for any type of seizure activity. CAT scan is performed to look to see if there's any increased intracranial pressure or hydrocephalus. You're going to be treating these patients with acyclovir, and that needs to be started as early as possible before the patient becomes stuporous or comatose. Maintain a patent airway. Recognize the signs and symptoms of increased intracranial pressure. You can allow the nurse tech to have these patients turn, cough, and deep breathe every 2 hours. Assess vital signs or neurological status frequently. And you also want to elevate the head of the bed 30 to 45 degrees to help the cerebral spinal fluid be able to be relieved from the brain. So the rest of this video goes into Parkinson's, dementia, and Huntington's disease. We have already discussed these particular disease processes, but if you want to look over them, they will be on your final Kaplan, and it's just always a good idea to go ahead and look over this. So this is the particular end of this video, and thank you.